next topic is COVID-related dysautonomia, and we are going to have a great talk on this from Dr. Mitchell Miglis. Dr. Miglis is a clinical assistant professor from Stanford University's Department of Neurology and Neurological Sciences, and a clinical assistant professor in psychiatry and behavioral sciences at the Stanford Center for Sleep Sciences and Medicine. He's board certified in neurology and sleep medicine. He treats a wide variety of neurological diseases with a special focus on autonomic disorders and sleep disorders. And I'm very lucky to be collaborating with him on some pretty cool COVID research. As many of you know, we started seeing a lot of COVID patients showing up in dysautonomia international support groups earlier this year. And Dr. Miglis was one of the researchers who took an interest in this very early on. So with that, Dr. Miglis, take it away. Let us know what we need to know about COVID.
Okay. Thank you, Lauren. Let me just share my screen. Okay, great. Thank you for the introduction, and it's great to be back at the conference virtually this year to talk about autonomic impairment in post-COVID syndrome. When Lauren asked me to give this talk, I accepted with some trepidation because this is truly sort of uncharted territory. I think as autonomic specialists, we're somewhat used to dealing in this sort of gray zone of medicine, but this is truly something that we don't understand much of at all. And so my goal in this talk is not to really educate you so much on mechanisms. It's more to generate more questions that hopefully together we can collaborate on for the answers. So my task today is to discuss what is known about post-viral dysautonomia, specifically the post-coronavirus syndromes. So we'll review what's little is known about post-viral dysautonomia in SARS and MERS, and then we'll talk about COVID-19. Then we'll review the documented cases that have been published thus far of dysautonomia after COVID, what we call the post-COVID syndrome or long-haul COVID. And then we'll review some preliminary data that Lauren and I have started on looking at frequency and severity of autonomic symptoms in post-COVID syndrome. And finally, we can hypothesize on some potential mechanisms and importantly, treatments and future directions. So these are my disclosures. I'm not an infectious disease specialist or an immunologist. As Lauren mentioned, I initially went into sleep medicine and interest in sleep disorders, but I was convinced to go into autonomic diseases and dysfunction as well by a very convincing Harvard professor with great hair named Roy Freeman. And I thank him for that because it's a fascinating and very important area of medicine. So all the medicine and understanding of diseases starts with observation and with patients and cases. So this is a patient of mine. This patient initially stimulated my interest in this topic. She came to our clinic, a 26-year-old emergency department nurse. Her only past medical history was mild exercise-induced asthma, some irritable bowel syndrome, although fairly healthy, very physically active. She developed a mild cough and shortness of breath on day 1 of her illness. So she had persistent symptoms on day 3, so she went to urgent care, had a nasal swab for SARS-CoV-2, that's the virus that causes COVID-19, and it was negative. She then developed chest pains over the next several days, which she described as sort of burning when she takes deep breaths, along with palpitations, tachycardia, and exercise intolerance. She started to be waking up at night with this tachycardia. And we hear this a lot from our POTS patients, that they'll wake up with racing heart and hyperadrenergic symptoms. The orthostatic intolerance and fatigue progressed over the next several days, and her cough worsened. So she went to the emergency department on day 10, where her nasal swab was repeated, and she was positive on the swab for the virus. She also had IgM and IgG antibodies tested, and they were both positive. Interestingly, her fatigue persisted, her respiratory symptoms improved, but her orthostatic intolerance and her tachycardia worsened over the next several weeks. And then she started to develop hypertension, orthostatic hypertension. And some of you with POTS may have this, that when she stood up, her heart, not only her heart rate would go up to the 160s, but her blood pressure would go up into the 150s systolic, and her typical resting blood pressure prior to her infection was in the low 100s. So we did tilt testing on her. This is her tilt. The top graph here is her blood pressure. Middle here is her heart rate, and then you see her chest expansion here on the bottom. This is supine, and then as we see when she's tilted upright, her heart rate goes up significantly. So her supine heart rate was 77, and then it increased to 142 on tilt. Her blood pressure increased as well, up to 130s, and sorry, her supine was 130, and her max upright blood pressure was 160. And she had these big swings in blood pressure, this sort of oscillatory blood pressure response, and we sometimes see this in hyperadrenergic states. And we included the chest expiration because when we initially tried to publish this, some of the reviewers questioned whether this was a hyperventilation response, which is a common critique in tilts and heart rate measurements in POTS. So we published this to show that her chest expansion was very symmetric, and she was not hyperventilating, and this was truly a physiological response. Interestingly, as would you would expect, her repeat nasal swab at the day of this tilt, which was about 6 months after infection, was negative. We repeated her antibodies, and her antibodies were negative as well. This is something that we're seeing with COVID is, the antibodies, typically maybe in mild initial disease, tend to be undetectable perhaps several months later. So we diagnosed her with POTS. There have been many talks on POTS on this conference, great one by Dr. Raj. So I won't belabor the point, but we may have a mixed audience for this talk. There might be some of you out there who don't know much about dysautonomia and have had COVID, and so I'll just cover some of this for that portion of the audience. And so she had an excessive increase in heart rate. She had what we call orthostatic intolerance, which is what we always look for in POTS. And these are pretty much any symptom that is worsened with upright posture. It can be anything from lightheadedness, which is classic, to vision changes, headache, nausea, shortness of breath. A lot of patients describe this the cognitive impairment or brain fog Dr. Rowe was speaking about with standing. And some, but not all, can faint, can lose consciousness. But it's not just the orthostatic intolerance symptoms that are a problem in POTS, it's everything else. So POTS affects almost every system in the body. And those of you with POTS are not surprised with this slide. You know this very well, but maybe those with COVID or post-COVID syndrome may not. So these are all the common symptoms that we see in POTS. Fatigue. Fatigue is probably most patients' chief complaint. It's present in almost every patient, if not all. GI symptoms of dysmotility, like Dr. Pace reviewed in her talk. Some patients have urinary symptoms, but that is not as common as some of the other systems that are involved. Pain is extremely common. Many patients are diagnosed with fibromyalgia. We're realizing now that a large proportion of those patients may in fact have a small fiber neuropathy. There is a strong association with hypermobility, and of course those patients do have a lot of joint pains if they have Ehlers-Danlos syndrome. Migraine is extremely common. We're seeing a lot of headaches in patients with post-COVID syndrome, and we can look at that data. Psychiatric, as Dr. Raj mentioned in his talk, patients with POTS don't have increased prevalence of anxiety, but they do have symptoms which mimic anxiety, and also there is a strong component of anxiety that may develop from chronic illness or from illness that's dismissed by many doctors. Sleep is a big problem. All patients have insomnia, and allergic symptoms. These are symptoms that we're paying more attention to recently, these mast cell symptoms, flushing, hives, dermatographia, so scratching the skin produces a raised inflammatory response, and a lot of food and drug allergies. So post-infectious dysautonomia has been recognized for decades. This has been described probably as long as doctors have been studying the effects of infectious agents. And there are a host of infectious agents that can cause autonomic complications. I put Zika in here, and of course coronavirus. This was from a publication in 2018. And as Lauren mentioned, almost 50% of patients with POTS do report a viral trigger. So this is a strong association. The takeaway from this busy slide is, in looking back through, this review and a lot of these pathogens that can trigger autonomic dysfunction, there's a lot of syndromes that look very much like autoimmune autonomic neuropathy, and you'll see with Dr. Vernino's talk, a lot of these sorts of symptoms described. So really autonomic failure, parasympathetic failure with lots of urinary retention and bowel obstruction, pretty severe syndromes. Caveat here is I think, POTS is perhaps not on people's radar at this time with a lot of these publications and may not have really been specifically assessed. But the syndromes that some of these viruses produce is a bit different from what we're seeing with COVID. And I thought this interesting case report from 1996, reading this, this is a autonomic neuropathy developing after EBV. Reading this is a sort of classic description of autonomic ganglionopathy to me. So our patient presented with fever, followed by acute, predominantly parasympathetic dysfunction and small fiber neuropathy, interestingly, as well as diminished taste sensation. The combination of large pupils, unreactive to light, but sensitive to pilocarpine, orthostatic hypotension, constipation, allodynia, and loss of pain and temperature sensations indicates severe autonomic neuropathy. And this patient had EBV virus in the CSF. At this time, they weren't treating patients routinely with IVIG, although that was suggested by the authors as a potential treatment. And then this is a paper that is out of the ME/CFS literature that I'm sure Dr. Rowe is well familiar with. And he touched on this, that in this community cohort, when they looked at all patients in the small community and followed them over time that had any infection, they found that prolonged symptoms of that initial infection were present in 12% of patients at 6 months, and 11% of those met criteria for chronic fatigue syndrome. But interestingly, the fatigue syndrome, the phenotype, although it was very stereotyped, it was not related to the specific virus or pathogen. It was more related to the severity of the acute illness rather than other demographic factors or the pathogen itself. This may or may not be the case with COVID, and we'll touch on that. So with this background, I want to go through what we know about post-coronavirus dysautonomia. So first we'll start with SARS. SARS was a pandemic in 2002 to 2004, affected a little over 8,000 people with a 10% mortality rate. In the few retrospective cohort studies that were done, they did describe a ME/CFS-like illness. And then this particular cohort by Moldovsky, who's a sleep specialist, they reported a cohort of mostly women, 86% women, who had persistent fatigue, non-restorative sleep, body pains that were very similar to fibromyalgia. Many of these patients had persistent lung abnormalities on pulmonary function testing at 6 months. The duration of disease for this cohort was around 2 years when they sampled them. And all of these patients were healthcare workers, and almost none of them were able to return to work. They were on disability from this illness. This study, a little larger study, looked at patients who had ARDS from SARS. In this cohort, it was fairly evenly split. 47% were women. 109 patients that were evaluated at 3, 6, and 12 months after discharge from the ICU for ARDS. And in each visit, the patient had pulmonary testing, chest x-ray, and their primary outcome measure was sort of an exercise test, 6-minute walk test with oximetry. And what they found is that many patients, even at 12 months, 6 and 12 months, had a restrictive lung pattern on PFTs, and 20% still had abnormal chest x-rays. At 1 year from the illness, the patients at an average were only at 66% of predicted exercise capacity on that walk test. So the authors concluded that the results suggest the inability to exercise is primarily due to extrapulmonary disease, even though they did have these abnormalities on lung function. They found a lot of these patients lost a significant amount of weight and were very deconditioned throughout this follow-up period. So they attributed a lot of the dysfunction to that, although autonomic function was not assessed in this cohort. The only study assessing autonomic function in SARS was a very small study of only 14 patients, evaluated 6 months post-infection. And they did stand testing on all these patients and found that 4 out of 14 had abnormalities. None of them had orthostatic hypotension. POTS was not specified, so it's unclear if they were aware or evaluating for POTS. One patient did have signs of a small fiber neuropathy. 85% of this cohort were women. 2 developed persistent headaches and sleep disturbances, and all had chronic fatigue. So there are some hints here of what's to come and what we're seeing with COVID. These 2 studies looked at tachycardia in SARS. Tachycardia was recognized very early on as the most common cardiac manifestation. Not surprising that it would be in an acute infection. Most people become tachycardic with acute infection. But they found that most of the patients that they looked at, 64% again, that had significant tachycardia were women. And then in another study on 3-week follow-up, they found that this tachycardia had persisted in 40% of patients. So that's all the data we really have on SARS, and there's even less on MERS, because this was a much smaller pandemic, coronavirus pandemic in 2012. 2,494 cases, much higher mortality rate, 35%. So there's very limited literature on chronic form of the illness, and there's no literature on autonomic dysfunction. Although there are reports in this paper on acute sensory neuropathy, which may have some overlap with autonomic impairment, reports of Guillain-Barré syndrome, which can have autonomic dysfunction as part of it. Interestingly, the neurological symptoms, in this paper were delayed 2 to 3 weeks, sort of suggesting perhaps an immune-mediated response. And I think that's some signal we're seeing in post-COVID syndrome, that the chronic symptoms and the autonomic symptoms can emerge later after several weeks. So with that background, let's get into COVID-19. So as we all know, the center of the outbreak was in the Wuhan province in China, December 2019. The first US cases were reported in January 2020, actually in our county here, Santa Clara County in California. Was declared by a pandemic by the World Health Organization in March 2020. And as of yesterday, and in putting together these slides, there were 39 million cases. So we are obviously dealing with a different animal, a much, much larger scale than the prior coronavirus pandemics. 39 million cases. And in the US, we always like to be the biggest and do things our own way and the best, and we're definitely winning that race in coronavirus cases, unfortunately. Mortality rate is still unclear, but probably around 2 to 3%, so much lower than the other coronavirus pandemics. The point there is that most patients do recover. Additionally, some reports suggest up to 40% of patients may be asymptomatic. And so the long-term outcomes, we're still very early on in the saga here, so the long-term outcomes are unclear. But some data suggests, and a lot of this is from crowdsourced data, that 10% of patients may develop chronic symptoms. So if you look at the numbers here, 39 million cases, 10% of that we're going to be seeing this for some time to come. And this is, if we're in a difficult spot now with our economy, with it does lead to significant disability. This is going to be a huge problem. I won't get too much into the acute complications of COVID-19 with dysautonomia. I'll just touch on this with this one paper. This is a paper out of Spain in their hospitalized registry. A lot of these patients had severe COVID, so all were hospitalized, but 57% had neurological symptoms. Loss of consciousness is fairly common on initial presentation, and this may involve viral effects on the autonomic centers in the brainstem that control blood pressure. Almost 3% of patients had dysautonomia, although that wasn't specifically defined in this paper. The authors concluded, as far as mechanisms, that dysautonomia is suggestive of COVID-19 affecting small unmyelinated fibers. Nevertheless, the central origin of dysautonomia cannot be excluded. They haven't found the SARS-CoV virus in CNS structures. So it's unclear how much it actually penetrates into the brain or the CNS. But they say that unlike that seen in CNS, there's no evidence that SARS-CoV-2 is capable of directly damaging peripheral nerves. Therefore, it seems more likely that the damage is exerted indirectly by a cytokine storm or due to a disimmune mechanism. And so what is post-COVID syndrome? We'll get into the chronic autonomic complications of COVID. So the prevalence of these symptoms after the acute, what we call the para-infectious period, when patients are actually viremic, is unknown. And there's not really a clear definition of post-COVID syndrome. The duration of symptoms required for this diagnosis is not defined, although most of us in the medical field in defining chronic conditions would probably agree on at least 3 to 6 months of persistent symptoms. The CDC initially conducted a telephone survey with COVID survivors in April 2020. In 274 survivors, they found that at approximately 3 weeks after initial infection, 71% still had fatigue, as well as cough and headache. And in another study of 143 Italian survivors in the Lombardy province, we all remember those harrowing depictions of the initial wave of COVID-19 in Italy, in Bergamo. They found that 87% of patients still had symptoms 2 months later. Vast majority had fatigue, difficulty breathing, and chest pains was also common. So now they're doing follow-up studies in this population in Bergamo. This has not been published, but they are seeing that, now 4 months after that initial horrible wave that they had, they're bringing patients back for testing, and they're seeing what was seen after SARS, that 50% still have symptoms, 30% have breathing difficulties, and actual lung scarring on pulmonary testing, and 30% have clotting abnormalities, although that hasn't been really specified what that means. But there may be physiological complications that develop, not just disimmune complications. And these are just a few reports noting autonomic symptoms in this long-haul COVID syndrome. Ravindra Nath at NIH has described this in some patients, noting tachycardia on exercise or standing, night sweats, gastroparesis, constipation, vasoconstriction. Those with POTS can identify with all of these symptoms. And then this group out of France in the Paris area noted that since mid-May, they were seeing 30 patients a week with persistent symptoms. Most were women in the 30 to 40-year age range, and most were previously healthy. Many of them had initially mild symptoms. So this is sort of the paradox of COVID, and I think this extends to all aspects of this disease. It's very hard for scientists to wrap their heads around this condition because the initial severity of symptoms may not indicate how severe or how chronic the post-infectious period may be. And some patients may be asymptomatic with the disease. So this may go against the dogma and ME/CFS literature that the initial severity of the illness predicts the duration of the chronic form. Also, we're seeing that a lot of patients have this waxing and waning, relapsing, remitting sort of illness. And that's not uncommon with dysautonomia. As we know, patients can feel very well one day and then have a relapse of fatigue. Some of them feel feverish, shortness of breath, chest pains, tachycardia, headaches, and anxiety. So I think this condition really became, I think, recognized on a more global scale from crowdsourced data and from patients. And this is going to be an important part of, I think, research going forward due to how quickly this data can be broadcasted. So the first study was performed by this group, the Body Politic. They looked at 640 COVID survivors that had symptoms persisting at least 3 weeks, and almost half of the respondents actually were not tested for COVID-19. As we remember, in the wisdom of the CDC, we were not able to easily get tested initially with this pandemic. So most of these patients weren't tested. The majority were never hospitalized, so they had fairly mild forms of the disease, and they were in fairly younger ages and vast majority of women. This cohort, they did have 58% listing at least one pre-existing condition, with asthma being the most prevalent, so it's something to keep in mind. And again, 70% experienced fluctuations in symptoms. It wasn't monophasic, sort of waxed and waned, and most patients had not recovered. This is just showing the pre-existing conditions in this population, so fairly high percentage of asthma. Vitamin D deficiency was the other most common pre-existing condition. And I put this up here just to sort of emphasize this link with POTS, that this is a description of a patient's, I think, pre and post POTS. So graph on the left here is patient's exercise capacity prior to onset of symptoms, with most patients either moderately or performing moderate or very vigorous physical activity, and only 2% sedentary. At the time of the survey, 45% saying they're completely sedentary, can barely get out of bed. And these are some quotes from patients. "I can't do any exercise. My heart rate goes up very quickly, and I get shortness of breath. One time I tried to do a regular exercise. I was too out of breath after a quarter of my usual time, so I stopped early." So, this is, to a POTS patient, very common story. And then finally, these are some of the neurological symptoms that they noted most commonly. Brain fog was the most common, and this seemed to persist during the 6 weeks of the study time. Trouble sleeping, very common. Lightheadedness, very common. And then we can see elevated pulse rate, also extremely common, as well as GI symptoms, not clearly defined what the GI symptoms were. And then this is just follow-up data from Karen Bischoff, who is really spearheading some of this. This was just sent to me yesterday, and reporting that in a lot of these patients, 300 respondents, 55 have reported developing an autoimmune disease. These are, again, crowdsourced data, so this may not be validated and not well defined, but still worth mentioning. 124 have reported developing dysautonomia. The degree of the functional disability seems to be profound. So almost half report difficulty with basic ADLs like grocery shopping, taking a shower. Many patients still believe that these symptoms can result in their death. Half do not expect to ever return to their pre-COVID health. A good amount say that they will never be able to return to work and feel like they'll need to file for disability. And many patients, understandably, feel that this is affecting not only physical health, but mental health. And here's a link to the to the document that we can post later. So that's some of the big picture and some of the crowdsourced data. So what do we have now in peer-reviewed literature? We'll start with case reports. So this is going back to the initial case I started with. This is our 26-year-old nurse. And just to reemphasize some of the themes here that we're seeing in these patients. So the autonomic symptoms that she developed, her POTS symptoms, really truly began around 2 to 3 weeks after her initial infectious onset. She also developed allergic symptoms with hives that she never had. Another interesting aspect of this patient was she was never really deconditioned. She continued to exercise, and she was able to go on hikes and exercise, but she would get tachycardic into the 160s on very minimal physical activity, although she continued to push through it. So she never was really deconditioned. She would describe these hyperadrenergic surges where it's just a huge adrenaline rush. She'd have diarrhea. She'd feel a need to pace. And this would just come out of nowhere without a clear trigger. Brain fog was very present in her case. We actually checked upright catecholamines, and her norepinephrine level was normal. We also checked her ganglionic acetylcholine receptor, looking for AAG that was negative. And we treated her as we treat really any patient with POTS, and she did improve with fluid salt, propranolol, and clonidine as sort of sympathetic blockers. She did get better and able to exercise more. And now at 6 months, her symptoms are still present, but I'd say she is significantly improved. I feel like she will return to baseline, or at least close to her previous baseline. So this is another case actually published by Dr. Novak, 64-year-old woman with a little older, with more significant past medical history, Lyme disease, and orthostatic intolerance, or OCHOS, as he described. She initially had symptoms of cough, fever, shortness of breath, but then 2 weeks later developed burning body pains, headache, and brain fog, as well as worsening orthostatic symptoms and actually urinary incontinence. So Dr. Novak treated her with IVIG, which led to resolution of the brain fog, the body pains, the urinary symptoms, and blurry vision. So treating some of these kind of parasympathetic components and led to 50% improvement in her fatigue and headaches. So this case was arguing for the benefit of immunomodulatory agents. We need a lot more data before we can suggest that routinely, but also to emphasize that some of these cases do really have a really autoimmune pathology potentially. So this is case 3. This is out of Dr. Grubb's group in Toledo. So this was a 36-year-old woman with no past medical history, initially very healthy, who had minimal symptoms. And then again, several weeks later, 3 to 4 weeks later, developed orthostatic intolerance, palpitations, fairly typical POTS symptoms. She underwent tilt, which demonstrated POTS, and she had a good improvement with fluid salt and ivabradine. And then finally, this is another case of mine, another patient I saw. This is not published, but a 33-year-old woman with some history of episodic hypertension during pregnancy, not preeclampsia, but she did have episodic hypertension and some orthostatic intolerance when she was younger, but very functional, very physically fit. Then she developed symptoms of fatigue, orthostatic intolerance, and action tremor. Her nasal swab was negative at this time, but her IgG for COVID antibodies was positive. And then 2 to 3 weeks later, she developed allergic symptoms with flushing and also GI symptoms of bloating and early satiety. And then she would start waking out of sleep with palpitations and tachycardia. We did tilt on her, and it demonstrated POTS as well. We checked her ganglionic antibodies, which I'm checking in all patients now, and it demonstrated weakly positive ganglionic antibodies. And as Dr. Vernino will tell you, this may not and likely doesn't reflect autonomic ganglionopathy, but it may reflect some underlying autoimmune disease. This is a non-specific finding, but worth mentioning. So what can we learn from these cases? Well, it's important to recognize these are only 4 cases. This is N of 4. This is not strong evidence, but this is how we build our future studies and understanding of this condition. All these cases were women. 3 out of 4 of them were under the age of 40. All patients developed their autonomic symptoms at least 2 to 3 weeks after the initial para-infectious symptoms of COVID-19. All patients had mild to moderate initial symptoms. And the symptoms that really stood out were this prominent cognitive impairment, brain fog, headaches. The headaches in the patients I've seen don't tend to necessarily fit with migraine. They tend to almost seem like a high pressure headache. They're worse when patients lay flat, sort of a headache affecting the whole head and feeling like a pressure. Fatigue is very severe. Orthostatic intolerance, of course, is common. And some patients may have this hyperadrenergic, this sort of increased fight or flight response with mast cell symptoms that they never had before. Some patients can have a pain syndrome. So this is suggestive of small fiber neuropathy, which we can see in post-viral dysautonomia. So those are the published cases thus far in the literature. Now I want to share with you some unpublished data. This is very preliminary data from an online study that Lauren and I are collaborating on, looking at post-COVID symptoms. Initially, our interest developed in the recognizing that many of these symptoms seemed very similar to POTS. So initially, we wanted to just understand the autonomic component, but we've since expanded that to really all COVID symptoms in the survey, and including also symptoms of MCAS and small fiber neuropathy. So we want to get a sense of how this disease evolves over time. The COVID-19 status, because this is a online study, is all self-reported. So that is a limitation. But this is the initial phase. Going forward, we're going to need to carefully phenotype and confirm, when patients were infected and what the date of the infection was. We do have a control cohort of confirmed Stanford COVID-19 survivors with documented nasal swab or antibody testing that we can compare these results to. And we plan to reassess patients up to 1 year to see how these symptoms evolve. So far, we have 1,400 participants. This is very preliminary. None of this was really filtered. But I wanted to get this out there and share with you what we have so far. So, of the patients that have completed this survey, 88% are Caucasian. Most patients have experienced symptoms between 3 and 6 months. They're now 3 to 6 months post their initial COVID infection. Most patients do report testing positive by nasal swab PCR. Other patients reported testing positive with antibody testing. A good amount have reported no testing. So in the future, we can filter some of these cohorts and see how the data changes. But they were diagnosed in this subset by an MD, and some patients said they had no testing and they self-diagnosed themselves. This is pointing out that most patients were mild to moderate. So most saw a doctor for their symptoms. Some did visit the emergency department. Less were admitted to the hospital, very few to the ICU, and very few intubated. So this is, again, this may be a bias of online surveys, right, or the population that we're capturing. But at least, and the theme, and this is what was seen in the crowdsourced data before, was that this is affecting patients with initially mild to moderate forms of the disease. And I think, this is the age range thus far. We're not really capturing that younger age here. I mean, this is a broader spectrum of age ranges with a fair amount of patients in their 40s, 50s, and actually greater than 65. So it'll be interesting to see how symptoms vary between these different age groups. So these were the symptoms patients reported at diagnosis. Sorry, this is a bit busy slide, but in the upper left are cardiovascular symptoms. So a lot of patients reported tachycardia and orthostatic intolerance. GI symptoms next to it, a lot of patients had diarrhea. We know that's can be a common presenting symptom in COVID. Mast cell symptoms, extremely common on initial presentation with flushing, hives, itchy skin, and pain in all forms, especially headache, body aches, not surprising with, acute viral illness, headaches as well. So some of this is not really a breakthrough, but we'll compare it to their persistent symptoms in a minute. Most patients on initial presentation had fatigue, brain fog, temperature intolerance. A lot of patients had rashes. And the rash breakdown here, 60% said it was itchy, 30% said it was painful. We specifically asked the question if patients were diagnosed with shingles. Most patients were not diagnosed by their doctor with shingles if they had a rash. And again, pain in all forms, very common. So these are the persistent symptoms. Persistent meaning, at least several months. What has not gone away? And if you look down here at the bottom graph, this is the sort of type of the expression of the symptoms. We asked, have they worsened, have they improved, have they waxed and waned, or have they stayed the same? Most patients are saying that their symptoms are waxing and waning. They're coming and going. I heard one patient describe it as the corona coaster. With one symptom complex going away, a whole new set of symptoms can come in. So it's really difficult to understand and to treat. So up top, we have those initial symptoms that patients reported, and then persistent symptoms thus far. Not a great graph comparison. We have to look at the scale here, but I'll just point out that the brain fog seems to persist. Again, that's one of the most common symptoms we're seeing. The fatigue seems to persist. Difficulty sleeping is also quite common. And what about the orthostatic symptoms? Tachycardia remains common. It does improve, but tachycardia and palpitations and lightheadedness are the most common cardiovascular orthostatic symptoms. What about GI? GI seems to improve a bit more. If we look at the numbers, the diarrhea and nausea improves a bit, but at least almost 400 patients are still reporting bloating, and it's unclear if these patients actually have developed any form of post-viral dysmotility. That'll be interesting to look at going forward. And then what about pain? So body aches and headaches are still very common. Nerve pains are not as common as I was expecting, but still a fair amount of patients reporting nerve pain. So it'll be interesting to see if some patients do develop a small fiber neuropathy as a result of this. And then finally, allergic symptoms. So flushing, itchy skin, these are persistent symptoms that patients are reporting. So finally, we can talk about potential mechanisms. I mean, this is extremely theoretical, but what could be going on in the syndrome? What's causing this condition? Well, persistent cardiac or pulmonary injury. I mean, that should be emphasized, because we do have this literature from at least SARS that showed that a lot of patients had persistent pulmonary function abnormalities. And now we're seeing in Bergamo that a lot of these COVID survivors have abnormal function testing. So this is something that we need to recognize and pay attention to before we diagnose someone with just POTS and tell them to exercise. That some patients may have pulmonary damage from this condition. Deconditioning, as Dr. Rowe mentioned, is part of the story, but it doesn't explain the spectrum of the illness. What about direct invasion of the virus into the brain of the brainstem? This is one hypothesis. There are autonomic structures in the brainstem that do have the ACE2 receptor that the virus uses to gain entry to the cell. And syncope was a common presenting symptom in a lot of the Italian cohort publications. They have demonstrated that they can infect the brainstem of rats if the SARS virus was given nasally. That they showed that the virus can travel into the brainstem with SARS. This hasn't really been demonstrated in COVID-19, however. Could there be damage to the peripheral nerves? Could there be small fiber neuropathy potentially in some patients? And this is something that we've previously called neuropathic POTS. So there may be some overlap here. More likely, I think there could be more indirect injury. With some groups have shown that there's activation of glial markers of inflammation in the blood, and this theory of a persistent inflammatory response is very appealing, given the time course of when these symptoms come out several weeks after the initial viral infection. And then what about mast cells? Mast cells also express the ACE2 receptor. Mast cells may be involved in the cytokine storm seen in ARDS. And in this publication by Dr. Afrin, who's one of the MCAS experts, he does argue that we should consider H1 or H2 blockers in some patients, either in the acute period or in chronic syndrome. So I won't belabor these slides. This is just, these are old slides that, suggested potential mechanisms of POTS. So we've had this conversation in the POTS field for quite some time, trying to wrap our heads around POTS as a syndrome. So many of these mechanisms, I feel, may give us some insight into COVID with neuropathic, hyperadrenergic, volume abnormalities that we see in POTS patients. Most recently, autoimmune autoantibodies that we're finding, and Dr. Fedorowski will talk about this in the conference. Mast cell activation.
Dr. Miglis, I'm sorry, I don't want to cut you off because this is all really good stuff, but we want to take some Q&A. Are you almost done, or can we hop into the Q&A? 2
slides.
Okay.
So very quickly on treatment, I think we're very early on in this. So I want to emphasize the point that before we just jump to fluid and solid and exercise, patients should be evaluated completely. We should rule out any cardiopulmonary disease, any thromboembolic disease that may be persistent. And then again, I think treatment is individualized, just as in POTS. And the choice of pharmacological agents should be individualized. And immunomodulatory treatments like IVIG, we're not there yet to recommend those as standard therapy. I think if there are clear markers of autoimmune disease present, if we can find autoantibodies, then we can consider it. And then vagal nerve stimulation, as you heard in the talk last night, is a very interesting thing to think about for these patients. So final slide, future directions. Where do we go from here? Well, we need to establish registries, I think, open access to data. We need to share the data. We need to have longitudinal studies of patients assessing all these markers. We need to understand what puts certain people at risk for this disease, what immunological markers put people at risk. And then finally, we should, care for patients. We should think about post-COVID centers of excellence, multidisciplinary centers for long-term care. And Finally, this is our survey. If anyone's interested, we'll publish this link and we'll keep the survey open at least a few more weeks after the conference. And hopefully with your help, gain a greater understanding of treating this disease. That's all I have. Thank you for your attention.
Thank you so much for a great talk on a topic that is hard to lecture on because it's so new. And doctors always like to have lots of rigorous data to present. So this was sort of, a very interesting topic, and really want everyone to be aware that this is evolving so rapidly. So a lot of our audience members are people who have dysautonomias, POTS, orthostatic intolerance and whatnot, that have nothing to do with COVID. They've had it for a long time for some other reason. And so they're wondering, do we have any data showing what happens if you have POTS and you get COVID, or if you have orthostatic hypotension and you get COVID, what happens to you? So have you seen any of that clinically?
So I have seen it in a couple patients. I have seen that in those patients with pre-existing POTS that have gotten COVID, they do have a fairly severe exacerbation of their POTS symptoms. So I've seen a fairly severe relapse of POTS, along with some new symptoms, some of the pulmonary symptoms and chest burning, things like that, that seem to be more unique to COVID. So there's no data on this. I think most of our POTS patients have been extremely careful, so not many have been infected. I've only seen a couple, but I think, yes, there is a major risk of relapse with COVID.
Yeah, we had asked our medical advisory board about this when COVID first started. Do our patients need to, remember in the beginning of COVID, there weren't even recommendations for everyone to wear a mask. It was sort of like a new concept. So they had said at the beginning that, people with POTS and syncope and orthostatic intolerance have, generally speaking, not everyone, because there are individuals with certain immune deficiency diseases, but have generally speaking, an immune system that, is not like a person with chemo or with a major immune deficiency, so that they're sort of thinking that they'd be at average risk of getting COVID, but they did acknowledge that anytime people with dysautonomia get a virus of any sort, they tend to get a flare of their dysautonomia symptoms. So it is important to make sure you're protecting yourself and your family. But at the same time, so we've been tracking informally, not through rigorous research, on our support groups, asking patients what's happening if you've had POTS or you've had another form of dysautonomia and you got COVID, what's happening? And the good news is that we have only seen a handful of patients that ended up intubated or in the ICU. Most patients were able to ride it out at home, maybe with just one visit to the hospital or to their doctor for diagnosis. It varies because we have patients with a lot of other diagnoses within the dysautonomia world. But if anyone needs information on this, we have, we did a webinar with Dr. Blichstein on what dysautonomia patients should know about COVID that we can post in the links on the chat, on the Zoom chat. If you look at the bottom of your Zoom panel, there's a chat. And so we'll get the links posted in there. And also, we have a website, dysautonomiainternational.org/coronavirus, that has information for dysautonomia patients. So let's jump into some questions about COVID-related, dysautonomia that's been triggered by COVID. We had a lot of those questions too. So I'm sure the question every patient wants to know, which I know you don't have a final answer to, is what do we expect to happen to sort of long-haul COVID patients in the long term? Do we think that they will have a similar post-viral dysautonomia prognosis as other post-viral dysautonomia patients? And what is that prognosis generally?
Yeah, I mean, the answer to that is, as you can imagine, is we don't know.
Yeah.
I think the wrench in the equation here is we're seeing that most of the patients that are filling out these surveys with persistent symptoms had very mild forms of the disease initially, but it's not clear if that's just a sampling bias, and if that goes against the ME/CFS literature where the severity of the initial disease predicts the outcome. I mean, I'm optimistic, as I always am with post-viral dysautonomia, that we can get patients better. I mean, that's the theme I try to emphasize, is we do have some framework in POTS and how we treat patients, that we can get most patients better. But as in POTS, a majority may not completely return to baseline.
Yeah. I think we should be, I know what you're saying when you say that, but for our audience who is sort of new to this vocabulary, in POTS, we have research showing that a majority of patients do have some improvement over time. And that's what you mean by better, is that they are improving to some degree. And that varies. Some people improve a lot, some people improve a little. And then there's a smaller subset of patients that might consider themselves fully recovered. It's not 90% or something like that. A lot of, Dr. Miglis is one of the few doctors who does understand that concept, but there are a lot of doctors out there who will say everyone grows out of POTS, or you just need to exercise for 3 months and you'll be cured. And that's really frustrating for patients because that's not their lived experience. But so just think of it as we're all a little different, and most people are going to see some improvement. Like Dr. Rowe said in his chronic fatigue lecture earlier, most patients see some improvement, some people fully recover. And so our goal is to get everyone the best medical care possible to increase your chances of having the best recovery and the best improvement. And I think that's part of what this research is aiming to do. Can you talk a little bit about the relationship between mast cell dysfunction and a sort of hyperadrenergic state? And what is for our COVID folks who might be new to this lingo, what is the hyperadrenergic state, and does it seem to be does it have a relationship to mast cell dysfunction?
Sure. And again, another caveat, I'm not an allergist, but we're seeing this overlap a lot, in POTS patients. Hyperadrenergic state just simply means it's a heightened sympathetic response. It's sort of a fight or flight response that a lot of patients have either all the time or episodically, just triggered by very, very minor things. Tachycardia, sweating, heat intolerance. These are all common hyperadrenergic symptoms. The theory with mast cell activation is, these mast cells release histamine. Histamine can cause vasodilation, and it can cause release of other cytokines, other chemicals, which further increase the sympathetic tone. And this can be a vicious cycle. And so it's not much more than that is known about this, but all we know now is there's a strong association, and this is something that I think just in the past few years people are paying attention to.
Yeah. For people who are new to this kind of universe, if you're feeling these very allergic-y symptoms that seem different than your normal allergies or different than your normal health that you feel, it might be helpful to try over-the-counter, a Zyrtec, a Benadryl. You can combine H1 and H2 blockers. Do you want to explain that, Dr. Miglis, so that I don't give the wrong advice?
No, I mean, you probably know better than I.
Okay, so Pepcid and Zyrtec is my go-to.
Yes.
So guys, I think I actually had COVID back in February. I wasn't able to get tested back then, and I had a pretty crummy flare. And I have some lingering respiratory symptoms that have been going on for months, and it stinks. But I'm on Zyrtec, which is one type of histamine blocker. So Pepcid is something that normally you think of for stomach acid, but it's actually blocking stomach acid because it's blocking a histamine receptor, which is different than the histamine receptors that Zyrtec or Benadryl is blocking. So you can combine and look up H1 and H2 blockers, and you can combine those. I mean, talk to your doctor, but these are pretty over-the-counter things. And if you talk to your doctor, if you say, I think I have mast cell activation syndrome, most doctors will give you the eye roll. They don't know what that is. They don't think it's real. So don't be deterred. You can do some basic over-the-counter stuff if you're feeling these symptoms, and it might really help a lot. I noticed that when my sympathetic nervous system is angry, that's when I get more of the mast cell symptoms. So I think there's a correlation there, and that's the kind of research Dysautonomia International is funding, trying to figure out what is the relationship between these conditions and how we can target the treatments better. So Dr. Miglis, can you share just one last time the survey link the slide with the survey link. I did put the survey link in the Q&A, but people were asking for it. And we would love everyone's help sharing this survey, not just with the dysautonomia community, but anyone who's had COVID, whether they have long-term symptoms or not, or whether they had a mild case or a severe case, anyone over the age of 18 who had COVID or suspects that they had COVID, because a lot of people couldn't get formally diagnosed in the beginning. We would love for them to take this survey to share their experience. And the more diverse different types of cases and different types of people, the better the data will be. So please, and make sure you use a lowercase s in survey. There's actually a different survey that's using the same bit.ly link with a capital S, but it's not us. So thanks so much, Dr. Miglis. This was a great talk, and I'm sure we'll be hearing more from you on this subject soon.